You're welcome, Kath. Thanks for the nice introduction. We don't have that many in today. We only have 11, so hopefully more of you will join. I'm going to try and make this one fairly interactive if possible. I know it's we're going to have to do it through the Q&A bit. It's not going to be, you can't talk to me, but you can type it in. But hopefully we'll make this a little bit interactive and see how it goes. So welcome everyone. My name is Ash Rayarel. I'm one of the lecturers and clinical demonstrators on Tipton Training, and hopefully I've seen you all at some point on our courses. So right into it. So we've got to create natural posterior restorations. There's 2 or 3 techniques. One is stratification, where we have to build the anatomy ourselves, and second one is the stamp technique, where we can cheat a little bit. We can, you know, get something from the anatomy that's already there. So let's run through stratification. So to do stratification, it is quite complicated because you've got to understand tooth anatomy, shape. You've got to then work out exactly where the fissures go, and work out, divide the tooth, you know, into the number of cusps with the fissures. So it's quite complicated, but if you have a set system, it can be made a little bit more straightforward. It's a bit like a roadmap. So I will go through like a roadmap for you, which may make it a little bit easier for you to follow. And it's the same for every tooth. It's the same method of doing it. So if I was to ask you, which is the easiest tooth to do, a posterior tooth, which would you suggest? So type in, if you can, on the Q&A, what you think would be the easiest tooth to do. Right, 6, try again, Clara. Lower 7, yes. Why do you think lower 7 is the easiest? Well, I'll tell you why. Because a lower 7 has got 4 cusps, and the 4 cusps are equal in size. So that means that we can just make a mesiodistal fissure and a buccolingual fissure, and it divides the tooth into quarters. And so dividing that tooth into quarters makes our life very easy. Also, it's quite a big tooth to work on, so it's quite easy, because some of you might have thought it might have been a premolar. And yes, a premolar has less anatomy, but it's much smaller to work on. So lower 7 is the easiest tooth. And these are the stages that we use. So this is a diagram just to show you the stages. And what you do is you start with your midline fissure. Just stay with me on this picture to start with. This midline fissure, as you can see, it doesn't go right across the tooth. It stops. So your midline fissure only goes about that far, leaving a little bit of space there for your marginal fissures. Then we divide the tooth into from buccal to lingual, and this time it goes right across. And the clue is where the tooth constricts like that, because where it constricts, or where there's a fissure buccally or lingually, is where this one starts, and it goes right across. But your midline fissure doesn't go right across, it sort of stops just before. Then where it stops, you put your marginal fissures in, which are called crow's feet or marginal fissures. They look like crow's feet. So from that point on, you'll have virtually all of the tooth carved. Then what you need to do is you need to shape the cusps. There's 4 full-size cusps and into sort of rounded teardrops. So we make these teardrop shapes with it's like a triangle, a rounded triangle, with the base side, apex to this side. So you make those, and the last thing you do, not the last thing, but the last but one thing is just deepen these fossa. You know where it dips in, just deepen those fossa. And then the last thing you need to do is you need to put these dissectional grooves. Now these dissectional grooves are a line which runs throughout the arch, and it's where the marginal ridge sort of dips. And that dissectional groove follows right round the arch. So your distal one's going to be slightly buccal, your mesial one's going to be slightly lingual, and then the distal of the 6 will follow there, and then the mesial one will be slightly more lingual, and it follows round. Those are the dissectional grooves. Now, this is how you would carve a tooth or wax a tooth up. Obviously, if you were doing it in composite, you'd do cusp by cusp, you'd build up these cusps. But if you have an idea of where the fissures are, then you can build the cusps accordingly. So remember, in a 7, we have 4 equal sized cusps. So the fissures make those cusps, divide them into 4 equal sizes. So what do you think would be the difference with a 6? Where would the difference lie with a lower 6? Let's do question and answers again. See if you can. What's the difference between the 7 and the 6? There's deadly silence here. No, okay. Okay, no, not distal cusps. How many cusps do you think a 6 has? A lower 6 in total. 5, excellent, Clara. So 5 cusps. And so I'll go through it. So the difference is this has got 5 cusps. So it automatically becomes a different, you can't do your straightforward cross. So it's going to be, there's 3 cusps on the buccal aspect and 2 cusps on the lingual. So your lingual fissure will start halfway, but your buccal fissure won't start halfway. This starts nearer. Cusp is larger than it's almost to the midline, but right, it starts here and then it comes upwards. Then what we do is we start halfway, because the 2 lingual cusps are the same size. We start this halfway, and then this comes down and across to divide this into thirds. So if you see, it comes over, across, and down. And we can then join those 2 areas up here to make like a little oblique fissure. Then we need to do this distal fissure. So this will come down here to then make the marginal ridges. So if you see, this comes down to make your distal groove, dividing this into thirds and dividing this into halves. So that fissure there divides that into 2 halves. That fissure there divides this one, and then this fissure, which comes across from there, divides this into thirds. Then you can put your crow's feet in, or your marginal fissures. Then you can deepen your triangular fossa, and then you can put your dissectional grooves in. So I hope that makes sense. It's not as easy when it's not interactive, but I'll just run through that again quickly with you. So because it's in thirds, this buccal fissure starts further mesial. It comes across and then goes up. Your lingual, because these 2 cusps are about the same size, starts about halfway along the tooth. It then comes down and then goes across, making this other cusp. You then get a distal fissure which comes down like that. And then you do your marginal fissures, shape your cusps, and then deepen the fossa, and then the dissectional grooves. So this shows you your first bit, your second bit, coming across. Don't forget to link these here with an oblique fissure. This then continues down to give you distal fissure, and then you've got your marginal ridges, marginal fissures. Shape the cusps, triangular fossae, and the dissectional grooves. You can see how it follows through. So that's a 6. So how about a 5? How many cusps does a 5 have? Q&A again. Is anybody going to answer that? How many cusps does a lower 5 have? 3. Excellent, make whole. Three cusps. So we've got 2 lingual cusps and we've got 1 buccal cusp. So where it's going to differ, it's just going to come across, and then here we've got a fissure, but here we'll have 2. So let's just show you the diagram. So we'll have a midline fissure, and then we'll have a lingual lateral fissure like that to divide these 2 into 2 cusps and 1 buccal one. We've got the marginal fissures, shape the cusps, triangular fossae, and dissectional grooves. Can you see how it's the same process for every tooth? All you've got to know is have this roadmap. You've just got to know where the fissures are and where the cusps are. Then your restorations will look more lifelike. You'll need less occlusal adjustment, and they'll feel better. They'll perform better, because if we carve better, it's cusp to fossa relationship. So they'll perform better. The food will then be pushed to the middle of the tooth, so they'll trap less food. So all in all, you just get a better restoration by taking your time. So a lower four is very similar to a 5, but it's only got 2 cusps. So it just comes across, and then marginal fissures, triangular fossae, and dissectional grooves. So your 4 is like that, where you've got just the marginal fissure, and then you've got your marginal ridges, marginal fissures, or crow's feet, shaping the cusps, deepen the triangular fossae, dissectional grooves, and we're complete. So that's your 4. So going on to lowers, we'd start with the lower 4, which is very, very similar to the upper 4, in that we have a midline. Sorry, I've got it wrong way around. We're doing the uppers now. The upper 4 is very similar to the lower 4, where we've got midline fissure, crow's feet. The only thing with the uppers are this fissure is quite narrow. It doesn't extend as far. It's quite a small fissure. And the marginal fissures are much wider and bigger. So you've got quite a narrow, sorry, I've gone on to the 5. So you've got quite a narrow mesial midline fissure, but bigger marginal fissures. And you've got your triangular fossae and the dissectional grooves just the same. And literally the 5 is exactly the same. It's just like a 4, but a bit more rounded. This time the dissectional grooves are fairly straight like that, but very, very similar. So let's come to the upper 6, my favourite tooth. So upper 6, how many cusps? Can we have a Q&A? How many cusps in an upper 6? Upper right 6, how many cusps? 4, Shazza, that's very good. Yes, 4. So which is the biggest cusp, or are they all the same? Are they all the same size? Or if not, which is the biggest cusp? No, not distopalatal, Shazza. Try again. Distopalatal is actually the smallest cusp. No, not me. Dr. Nias got it right. But there's 2 palatals, and you're right. It's the mesiopalatal cusp, which is the biggest one. So the buccal cusps are all the same, both the same size, but the mesiopalatal one is the biggest cusp. So if we look at that, so if you imagine the mesiopalatal cusp is the biggest cusp, what's going to is the buccal side is, so if it's a right, the buccal side is going to start at the midline and then go up. But because the palatal cusp is mesiopalatal is bigger, the fissure from the palatal side is going to start lower down, and we're going to get 2 L's with an oblique fissure. So I'll just show you that. Sorry, my computer's just. So the mesiobuccal comes like this, from halfway and then goes upwards. But because the mesiopalatal is this palatal fissure starts a lot down, so that we're going to get a bigger cusp, and it comes across like that, leaving an area to form this oblique ridge. Now you can go and do the marginal fissures first, because it's a simple movement then of doing that, and then put your oblique fissure in, or you can do these L's and put your oblique fissure in, whichever way you prefer. You shape your cusps, make your the dissectional grooves, and that gives you a 6. But you can see how this mesiopalatal cusp is the biggest, distopalatal is the smallest, and the buccal cusps are about the same size. That's how you do a 6. So a 7, what do you think the difference is between a 6 and a 7? Hopefully some of you will answer. Is there any difference between a 6 and a 7? And if so, what's the difference? I think I've got you stumped there. Nobody's answering. So the difference between a 6 and a 7, the palatal is smaller. So as we go further back in the mouth, the mesiopalatal cusp becomes bigger and the distopalatal becomes smaller. So in that case, the lingual fissure will start even lower down, so that we get a bigger mesiopalatal cusp, and this oblique ridge will become steeper. Because it's further down, we'll get a much steeper oblique ridge, and we'll get a distopalatal cusp. So I'll just show you that. So the buccal one is the same. The buccal fissure start to divide these two into two. But this one starts a lot further back distally. So it comes across, it's not got as an L, it's more like an angle, and that then makes this oblique fissure much straighter. Fissures, shaping the cusps, obviously getting the oblique ridge, shaping the cusp, triangular foci, dissectional grooves. So you can see 7, this cusp is much bigger, these two are about the same, and this distopalatal is much smaller. So I hope that helps give you a little bit of a guide. Now don't forget, when you're doing it in composite, you have to build cusp by cusp. You can't just put a composite in and carve it out. It's not like that, because you get too much shrinking issues. You have to do cusp by cusp, incrementally build them. But this gives you a bit of a roadmap. You know, if you have these images in mind, it gives you a nice roadmap to see, well, how do I do and follow it? And all having that picture in your mind of SAR and where the fissures are, it just makes everything so much easier. So the stamp technique, this makes life so much easier, because it's a little bit like cheating, you know, because it eliminates the stages for stratification, creates a completely natural anatomy, because even though these are roadmaps, all teeth are different, you know, and there will be some secondary anatomy and stuff that you can't actually, we're not good enough to put in, or certainly I'm not good enough to put that in. So this creates a more natural anatomy. And the best thing about it is it reduces the need for occlusal adjustment, because we're sort of copying what we already have. And the most infuriating thing is we spend all that time doing everything. It looks beautiful, but then when we come to adjust the occlusion, we take out all that we've put in. So this is really good in that it prevents the need. So I'll just go through the technique with you. So if you get a tooth like this, you know, it's a virgin, any restoration in, and it's got nice anatomy and it's not had anything done to it, but you know, as soon as you open that up, it's going to be a big cavity. What you do is you take pressure of the occlusal surface of the tooth, and you can use anything really that you want. I like to use temporary crown material, you know, like Pro Temp or Luxatemp, because it does get into the grooves and it's quite rigid. So when you use it, it's quite positive. So I like to use that, but use flowable composite. You can use putty, you can use different, whatever you've got in hand. Obviously, flowable composite is very expensive, you know, so I would, I sold my practice the 1st of March. All this happened, so there are, my friends called me Nostradamus, you know, he could predict the future, so they're all saying that I could predict the future because I sold just at the right time. But being an ex-principal, I know how expensive flowable composite is. So I would encourage you to use, you know, something cheap like temporary crown material. So what you do is you take an impression with your temporary crown material. Now, unfortunately, don't put PTFE tape in. This picture was one that's after, you know, in a later stage, but I needed to show you what you do. So imagine that PTFE tape there. You just put your flowable composite in, then you get one of those micro brushes, you know, that you use to apply the etch, and you put that and bend it so that it's like a handle. And remember which side the handle bends so that you know which way around it goes, whether it goes lingually. If you're left-handed, you might do it lingually. If you're right-handed, you might do it buccally, and then just put it aside. So you've got your stamp, which is an impression of the occlusal surface before you started taking a drill to it. The next stage is to just cut a cavity. So you open the tooth up, clean all the caries out, and you'll end up with this sort of thing where everything's gone. All those fissures were gone because by the time you've opened it out, cleaned everything on, you know, on the, make sure the wall's clear and everything, you've lost a lot of tooth tissue. So what you then do is you do your usual etching and bonding, you know. I mean, I like to use the 7th generation bond where I'm just etching the enamel, and then I'll use a 7th generation bond, no etching the dentine, because the 7th generation bond does etch the dentine itself. It's not strong enough to etch the enamel, but strong enough to etch the dentine. So selective etching process, which I'm sure you all know about. Then I put a layer of flowable composite. Layer of flowable composite just fill the voids, because you know, if you put just straight composite, and when you're trying to pack it, you end up getting voids. And voids give you sensitivity because it allows the fluid in the tubules to move, and that's what causes pressure on the nerve. So you don't want voids. So a nice thin layer of flowable composite, and then incrementally I would build the dentine layer, leaving enough space for my last layer. So you know, you need to see how deep the grooves are. So it's usually a millimetre, 1.5 millimetres. So I'd build up dentine incrementally so that I'm not causing stresses, leaving just a very nice thin layer to put on. Once I've done the dentine layer, obviously I'll cure that incrementally. I will then, and I will keep some fissures in the dentine layer as well, just so that there's space. I will then put a final layer of composite on. I like to use a heated composite. So I'll warm my composite up, a final layer of warm composite. Now, if you don't have a composite heater like I do, you can warm it. All you do is you put the composite or the syringe in a laboratory bag, seal it up, and put it in some warm water, and that will make it more flowable, sort of thing. If you don't want to do that, you can buy a coffee warmer. You know, you get these filters that keep your coffee warm. They plug into the USB of your computer and they keep your coffee warm. They're £2 or £3 from Amazon, and you can put it on there. That would warm it up. Or a baby's bottle warmer, you know, again, putting it in the lab bag, putting it in the... So, but I do, place dentine layer in increments, leave sufficient space for final enamel layer. I do have a composite heater, and it wasn't really that expensive when I bought it, but I use it all the time. I love it. So there's space for your coils here. You can have one loaded in the gun and here, and here syringes go in. And this was £200-300, I think. I've had it for years. It's great because you just put it in, and there's 2 settings. There's a higher temperature and a lower temperature, depending on how viscous, you know, how flowable you like it. It doesn't make it really flowable. It flows in, and when you put the stamp on, it just molds better. So then what you do is, once you've put your final layer on, you put this PTFE tape, you sort of stretch the PTFE tape over it, put your stamp on, and then you just press hard on it with your thumb. Once you've pressed hard, it'll make a pattern of what you had before you started. So then you take it off and peel the PTFE tape off. PTFE tape is made of Teflon, it's plumber's tape, and it doesn't stick to anything. It doesn't stick to your composite, and it doesn't stick, it's an inert material, you know, it's non-stick, it's like what they make the pans out of. When you take it off, it won't pull the composite out, and it won't stick, and it separates this, because if you put this straight on the composite will stick to this, and it'll just pull out. So when you take it off, what you'll get is an impression or an indent of the occlusal anatomy, just as it was before we started. You will get some flash, obviously, so you'll just need to tidy that up. And if it's not done it properly, just put a bit more in and do it again. You know, you can repeat the process until you're happy. You don't cure it this stage. You make sure you're really happy with it. Any excess or anything you need to tidy up, or if you want to put a bit more anatomy in, if it's not, you know, you don't want to deepen the fissures, or if you want to put a bit of stain in, whatever you want to do, you can put that in at this stage. I personally don't like stain. I don't think it's nice. Patients don't like it. They then say, oh, well, you know, it looks dirty, or where's my filling? It just looks as it did before. So I tend not to bother with stain, but I know a lot of people do. So that's the finished thing, with really minimal adjustment needed, because it's an exact replica of what the patient started with. And you can see, you know, these are the for the buccal. This is the lingual fissure, and it divides the tooth. And this is the oblique fissure. And you can see all that anatomy that we talked about has been created, but in very little time, really, because it just needs that stamp going in. And that's a picture of what it looked like. Now, I could have put this stain in, but you know, my patient, when he saw these pictures, he was really amazed, and he could see which the new filling was. If I'd have put the stain in, he wouldn't know, and I don't think it's as nice. So I don't bother, but I have done in the past. And when I have done, people have sort of said, well, we don't like, can you take that stain off like that? So I've stopped with it now. I'll just check if there's any questions on that. Let's see. No, I think everybody seems okay with that. You seem happy enough? I can move on. So these are some more clinical cases, just to show you the technique, really. So this is a lower six, similar sort of thing. That's the clinical photo. It's had a fissure sealant, so with this one, you can't get as detailed anatomy as you would if there was no fissure sealant, but it still makes life a lot easier. This time, we've used a putty, you know, to show you that you can even do it with a putty, because with this one, because it was fissure sealed, putty is fine, because you don't need to have as much detail. So you still get the detail, but it's not quite as good as the temporary crown material. Then you cut your cavity, and all the stages are the same. Make sure it's clean. And that's the dentine layer. That's the final layer put on with the putty in X, and that's it all polished up. And this is an upper one this time. So that's the cavity, you can see. That's the cavity opened up. And that's the dentine layer. That's the enamel layer. That's it all polished up. Final thing. I think there's been a question, I'll just have a look. Sorry, I missed the beginning. Okay, come on. The purpose of the stamp technique is, you know, if you've got a cavity that's not been drilled before, you can get an impression of the occlusal surface before you start, and then recreate the same anatomy, exactly the same anatomy. So you don't have to do much occlusal adjustment. You get a very nice anatomy. You get much more detail. You don't have to occlusion. You know, a lot of the time when we've done the really nice, we've created nice shapes, we then have to start adjusting it, and it spoils it all. So it's a lovely technique to not have to Dr. Nias, how long do you keep the stamp in place? Just press it in just until it's made its indent and it's fully home. If you've got too much composite, it's sometimes a bit difficult to seat, but you'll know, because it's only small, and you'll know it's fully seated. And when it's fully seated, you can remove it, peel off the PTFE tape, and then just take off the flash, or repeat it. If you put too much in, if you've not got enough, you won't get enough indent. So you then take it off, put more composite in, PTFE tape, pop the stamp in, and it should just seat fully. And once it's seated fully, that's it, because you're not waiting for anything to set, you're going to cure it. So it's literally seconds. Imagine you doing a temporary crown and you've taken your putty index and you've loaded it up and you put it on. There you have to wait till it sets, and then you peel it off and you get an exact replica. But here you don't have to wait, you just put it on, take it off and peel off the PTFE tape. So that's how answers the questions. So this is to just show you, if you wanted to practice this technique on a phantom head model, this is how you would do it. So take a tooth. I mean, it would have been better on a lower 6, but this one's been done on a lower 7. So you take an impression first. So this time using temporary crown material. So we've taken an impression. That'll give you the fitting, that's the occlusal anatomy that it's going to create. You then cut your cavity. You then do your etching bonding, and then the first layer of flowable composite. Flowable composite, only about 0.5 millimeter. You don't want too much because it shrinks a lot. So you just want 0.5 millimeter meniscus just to fill out the microscopic voids and to stop pulling, because when you put composite on here, your dentine layer, it will adhere to this layer, even though it's set. Because of the free monomer, it'll adhere to that layer. So it'll give you that film where it'll adhere to, where you won't get voids. So once you've done the dentine layering in increments, so each increment you're building your dentine layer like this. Sorry. So that's your dentine. Remember, I've still kept like a Fisher pattern and leaving enough space for my stamp to seat, because if you put too much of this, your stamp won't seat fully, and then you won't be able to get the correct anatomy. So once you've done that, you put your final layer of composite in, you then put your PTFE tape, stretch the PTFE tape over it, and then place your stamp. So your stamp will come on. When you remove the stamp, this is what you'll get. Removing the stamp. This, so it'll have made the indent like that in the PTFE tape. Then you can peel your PTFE tape. Don't forget, we've not cured at this stage. You then peel your PTFE tape off and you'll have something resembling what you had before. So you may need to do it again, put it on, or you may need to remove some flash. But once you've done that, you'll have some sort of ideal anatomy like that. Then you cure. Once you're satisfied, you cure. Now, one thing you need to remember is, and that's the finished polished product, one thing you need to remember is about the curing is the C factor. So remember what C factor is. So C factor is contraction factor, configuration factor. And what it means is the number of free surfaces in relation to the number of surfaces in contact with the tooth. So what do you think the C factor is on a occlusal cavity? What do you think it will be? Let's go back to questions and answers. Does anybody know what the C factor is on an occlusal cavity? So remember, it's the ratio of the number of free surfaces to the number of surfaces in contact with the cavity. Come on, wakey, wakey, let's see. 5. Well, it's got to have 2 numbers, hasn't it? Because it's ratio. But you're right in 5, the first number's right. What would be the second number? Yeah, 5 to 1, that's right. So it's always going to add up to 6 because it's like a cube, isn't it? So we've got 6 surfaces. So it's always going to add up to 6. So on a occlusal, it's 5 to 1. It's 5 surfaces that are in contact and one that's not in contact. So C factor is a real problem in an occlusal cavity, or, you know, like an abrasion cavity. It's a problem because it's 5 to 1. So it's a very high C factor. So, sorry, that was one which we'd done with stratification. No stamp there. This was before the stamp. And that gives you. So when we're looking at C factor, I can describe it like a glass of beer or a glass of water. If you imagine you fill the glass up with water and you freeze it, the glass is going to shatter, isn't it? Because the water expands and it puts stresses on all sides. There's nowhere for the stresses to escape apart from the top part. So composite is the same. It's like a cube or a glass. And as it shrinks, it puts stresses on the walls. When it puts stresses on the walls, either the bond's going to fail from where the enamel and the composite meet, creating like a void. So I don't know whether you sometimes see like a white line on or a stain around composites. That's because of C factor. That's because it's pulled away and it's made stresses here. Either it breaks the bond or it'll break a few enamel prisms. But whatever the case is, you'll get a bit of breakage there. So C factor, you've got to really be careful. So therefore, you've got to build it in increments so that you're always keeping more free surfaces. So if you build up in increments, you won't get that. So if you imagine, if the water only touched this and it froze, it wouldn't cause this to break. Same if it was like this and like this. So keeping this like this reduces it. So the dentine layers, we can do that, but the final layer, we can't do that because we're putting it all in one and we're then curing. So you can't really do that with the last layer, but it is a thinner layer. So how else could we reduce C factor? How do you think we could actually reduce C factor? Well, if you think about it, if we slow down how this water or this beer freezes, if we slowed it down, the glass would have a chance for the molecules to just expand slightly. Because it's happening slower, it's not just going to shatter, it's going to happen slower. So there's less chance of breakage. So what we can do is we can slow down this setting. And the way to do it is to cure it gradually. So that's called ramp curing, where the intensity builds up slowly so that you do a bit of curing, then the glass has got a chance, or the composite's got a chance to shrink, but then the walls go with it, and then you do a little bit more. So that's called ramp curing, which if you've got a modern light, there will be a ramp cure feature on your light, and that just slows down the curing process so that you don't get as much shrinkage. The next way, I mean, if you don't have a ramp curing unit, the other way is just to start the curing from a distance and then come nearer, so that, again, it's a gradual thing. So if you've got an old-fashioned light, just start from a distance, come cure. Start again from a distance and cure. And once it's cured, you can cure it again properly. So I hope that makes sense about the C factor and how it works. So a class 2 cavity has a C factor of 4 to 2. So it's not as difficult. So a C factor here, because you've only got these two surfaces, you know, you've got two surfaces that are free and 4 that are in contact. So it's less of a problem. But although the C factor is less of a problem, the problem with these cavities is this contact area or contact point. That is the difficulty with class 2 cavities. So with a class 2 cavity, we should use sectional matrices. So with a sectional matrix system like this, you get what we call a contact area and not a contact point. So this is much, much better, and it stops us bringing the walls in. So if you imagine, if we use a circumferential matrix system and tightened it, the walls would come in. Then when we loosen it, the walls would go out. So that would then cause those enamel prisms to break, whereas sectionals matrices prevent that, because it doesn't actually close around the tooth and tighten it up and bring the walls together. If that happens, if you do get this splaying or contraction occurring, what will happen is you'll get sensitivity, you'll get pain on biting, and you won't realize what's happened, and that's the problem. So circumferential matrices should be avoided. And the way to do it is to make this into an occlusal cavity. So if you build the marginal ridge first, then you can take all this off and then treat it as an occlusal restoration. Now, because this is in composite, the C factor still remains 4:2. It doesn't, just because you've made this wall and made it into an occlusal, it doesn't become 5:1 again. It still stays as 4:2, because this area, it can still allow the stresses to pass through. So that's the way to do the class 2. That's the finished sort of product to show you how it's done. An MOD cavity has even less C factor, because it's 3:3 or just 1, which is very low C factor. So you're never going to really get problems with contraction. But again, avoid the circumferential, because when you tighten it, it comes in. And again, if you can do the 2, so this time you'll have to do 2 sectionals. So I tend to do 1 and then do the other afterwards. I don't tend to put both. I find there's just too much going on. So I do like the needle, build the marginal ridge, and then I do the distal, having already made the mesial one. I do the distal, and then treat it as an occlusal cavity and finish it off. Now, these are quite difficult to do because they're very small. They're very, very small teeth. So it's very hard to put the anatomy in there, you know. So a class 2 is very much like a pipe or a straw, where you've got the free surfaces on either side. So you can imagine you need to freeze it a lot sharper for this to break. You know, it'll give more than it'll break because you've got the 2 surfaces. So it's like a pipe. So hopefully that explains C factor to you. And, you know, obviously some of you might have been thinking, well, in the stamp technique, Ash is not thinking about C factor. Well, yes, I am. But you have to slightly change the technique so that you do, you know, you bear C factor in mind. Let me just see if we've got any other questions, because that's about it. It was a very short webinar. I didn't do a long webinar today because, you know, it's sorry, I'm off. So I didn't really want to do a long one because it's quite late, 8 in the evening started. So I hope you've enjoyed that. If you've got any questions now, I'm very happy to take them. So I'll wait a few minutes and see if we've got any questions. But it's been nice answering the questions as they came up. No, it looks like, hold on, there might be one. Is stamp technique used in posterior teeth only? Well, you could. I mean, you can modify it. You can use it in all sorts of different areas. You know, you can use it on anterior teeth if you want. I've tended to stick to posterior teeth, but there was one time where I used it and it was wonderful. So what had happened in this case was the patient had a distal cavity on a tooth where the rest seat fitted. The denture of the rest seat fitted in that aspect, and it had a cavity. And we had to do a restoration. And it was a student at university. I teach at the University of Manchester, and there was a student, and we were worried that we'd do this restoration, and the denture wouldn't seat. So they were thinking, well, we have to remake the denture. How do we do the restoration? If we can't seat it, the patient would be without the denture. So they were all scratching their heads, thinking, how are we going to do this? And I said, look, it's dead simple. Just take an impression of it. So we took an impression of the distal surface and of the occlusal surface, like a stamp, cut the cavity, did the dentine layer. The final layer, we just placed the stamp on. And of course, it created the exact depression for the rest seat, and it created the exact distal marginal, you know, the distal contact area. Obviously, there's no tooth in front of it, so it was easy. You could just put this in, and it created a whole sort of shape. And once it was done, the denture just slotted in perfectly. And, you know, they called all the people around, you know, all the tutors, the professors, they called everybody around to say, look, how easy this was. So you might have a case, you know, where you've got a denture rest seat that fits on an anterior, and it may become carious because, you know, these areas where you've got something staying, which is possibly why that rest seat became, the area around the rest seat became carious, because it's an area where food can lodge. So you may have a case like that, where you've got a cavity, it might be a palatal or a mesial or a distal, and your denture sits there. So you could use this technique, and it will save you a lot of hassle, and the denture will still perform the same way as it did before, because it sits in exactly the same position. Just see if we've got another question. How do I calculate 4 to, okay, yes, I will explain that. So it's a cube, if you imagine. So the free surfaces, the ratio of the free surfaces to the ones in contact. So if you've got a DO cavity, the free surface is the occlusal cavity, and whichever, distal or mesial. So you've got 2 free cavities, but all the others are in contact. So each wall, so you've got your buccal wall, your lingual wall, your distal wall, and the floor, they're all in contact with the composite. So that is 4 to 2. An MOD is 3 to 3. You've got the free surface on the distal, the free surface on the mesial, and the free surface on the occlusal. The 3 contacting is the floor and the 2 sides, the mesial, the buccal, and the palatal. I hope that, Canwell, does that explain it for you? So like the beer glass, in an occlusal, the beer glass, all those surfaces are in contact, and the free surface. So your occlusal is like a cube with only the top surface free. Yes, I can get better. I don't understand that. Hopefully it will make you better. You know, this webinar, that's the idea. If you can learn from it and use the technique. I don't we have any more questions. So if everyone is happy, I bid you farewell and hope you will use this this technique. It's very simple, straightforward technique. That's why it's not a long webinar, but it's so useful. And you know, sometimes the simplest things are the most useful. Anonymous attendee, hey Ash, yes. Ash, happy to see you in action again. Thank you, Hassan. How to avoid over contouring? Yes, that is a tricky one. So the best way to avoid that is there's an instrument available from Garrison, and it's a clear instrument, and it's a marginal ridge former, and that's the best way to do it. It's got like, it's a clear instrument, and it's got like a little place, and what all you do is you put your composite in, you place this clear instrument, and it makes that little dip, and it makes it, and you can, because it sits on this side, it doesn't make the margin too high, and because it's clear, you cure through it. Garrison make it, and if you get hold of the Garrison rep, he or she will be able to lend you one or show you one. Absolutely, it's the best way to do it, Hassan. Thank you for that question. That's a very nice question. Great webinar, thank you. I'm really pleased. Can you repeat the materials for the stamp technique? Yes, okay. So you can use the stamp, you can either use temporary crown material, Luxatemp, or any temporary crown material. Luxatemp is my favorite, or Pro-Temp. You then syringe that onto the tooth before you've cut the cavity. You also need a micro brush to then make a handle, and that's your stamp done. You will then need a PTFE tape. It's plumber's tape. You can buy that from the plumbers, or you can buy it from Amazon. It's called PTFE tape or plumber's tape. So that's what you use. That's the separator. Now, if you don't have temporary crown material, you can use putty to make this the stent. That's all you need. If you want to heat up your composite, a composite heater, hot water, or a composite, you know, like a coffee warmer. So I hope that answers your question. Anonymous attendee, what's your favorite bond? Okay, so my favorite bond for these cavities is a 7th generation bond. So I use Scotch Bond Universal, which is 7th generation. Now, with 7th generation, the best thing about it, actually, Scotch Bond Universal is 8th generation, because Universal means it bonds to other things. It's got silane and MDP and things like that. But what I don't like to do is I don't like to etch dentine, because if you etch dentine, what then happens is you then have to rehydrate it. It collapses the tubules. You can get sensitivity. You can over etch dentine. By using a 7th generation, I don't have to etch my dentine. So all I do is etch the enamel, and that way my dentine is unaffected. And this is why I love to use a 7th generation. So yes, that doesn't bond well to enamel if you don't etch, because it's the acid in that bond is not strong enough to etch the enamel. So if you etch the enamel, you're absolutely fine. So that's why I like to etch the enamel. Does it work without a pre? Yes, it does. It still works, but you sometimes don't get the detail, and it's a little bit harder to sort of press in. But it's very easy to warm the composite, Dr. Niehaus. You know, just get a bit of warm water, put a bit of composite in a lab bag, seal the bag, and warm it up and take it out. You know, if you've got compules, just one compule like that. So it's not that difficult to warm up, but you can try it. I would try it on an extracted tooth, or I would try it on a, you know, on a model. Anonymous, how long do you etch the enamel for? Now, that is a very good question. So do you think I would etch the enamel for the same time on me as somebody that's a teenager? Well, the answer is no. So a lot of people say etch for 20 seconds, 30 seconds. Well, that's not true, because what are we doing when we're etching? Well, when we're etching, we are demineralizing. We're taking out the calcium and the phosphate. So when we're demineralizing a tooth, how long it will take to demineralize depends on how strong that tooth is. So somebody that's lived in a fluoridated area, the tooth will be much, much stronger. So you would need to etch longer. So what you do is you etch for 30 seconds, wash off and dry. If you've etched for sufficient time, it will become frosted. If it's not frosted, you etch for longer. Now, it can go up to between 2 and 4 minutes. So somebody that's been in a very high fluoridated area like I have, I was born in Uganda, and there was 10 parts per million in the water there. So my teeth, to etch it, will take you 3 or 4 minutes. So how long you etch enamel for depends on the tooth, the age of the patient, and how strong that tooth is in terms of how much fluoride is in there. So it's anything from 20 seconds to 4 minutes. But the only way you know, and this is why I like using 7th generation, because you have to dry it fully. Now, if you dry it fully, you're drying the dentine. That makes the tubules collapse, and that won't allow you to have a good hybrid layer. So when those tubules have collapsed, you have to rehydrate it so that tubules come back up. So with using 7th generation, because I'm not etching the dentine, I don't have to re-wet. Yes, Lou, that answers your question. I don't have to re-wet if I'm using 7th generation. However, if I was going to etch the dentine and use a 4th generation, then I do need to re-wet. If I don't re-wet, my tubules have collapsed and my hybrid layer can't penetrate, so I don't get a bond. So by re-wetting, the tubules fill up with the water, they rise up, and then my bond can penetrate to become the hybrid layer. Now, with a 7th generation, what happens is you've still got the smear layer. You don't remove the smear layer because you're not etching. So the smear layer becomes part of the hybrid layer, and therefore the tubules are unaffected. So the water still stays within there. So they stay upright so that the hybrid layer can penetrate in. So I hope that makes some sense. Clara, thank you. I appreciate your kind comments. Hassan, which do you prefer more, V3 or Garrison? Do you know, it's horses for courses. So I like the V3. I do like the V3, but with the Garrison, that silicone, it gives you very nice contact. But I sometimes can't get the Garrison on because of the silicone. It sometimes just pings off. Whereas I don't tend to find that with the V3. But you know, they're both really good systems. It's just what works in your hands, Hassan. I think. I mean, I can say they both have their pros and cons, and both are very, very good. You're welcome, Hassan. Any more? Any more for any more? Or are we done? Okay, I think we're done. But if there are any questions, you know, you can always email them over to Kath or Lou, and she'll pass them on to me.
Thank you, Ash. That was fantastic. Really great presentation. So we really appreciate it.
You're welcome.
Hope you enjoyed it.
Yes, definitely. I did. I like the interaction. They were asking lots of questions, and that's what you want, don't you? You don't want to just keep talking at people. So it was
That's
very nice.
Brilliant. Thank you ever so much, everybody. Thank you for attending, and thank you again, Ash. We really do appreciate it. So have a lovely evening, everyone.
You too, Kath. Thank you.
Take care. Bye-bye.
Good night.
Good night.